Welcome to another session on surgery for undergraduates. Today's topic for discussion is colectomy or resection of the colon. This is the outline of the large bowel, which is made up of a number of parts. First is the cecum with the appendix here on the right side. Then the ascending colon, hepatic flexure, transverse colon, splenic flexure, the descending colon, right up to the sigmoid colon. This is the sigmoid colon, which joins the rectum at the rectosigmoid area. So this is the outline of the large intestine. Next, what is colectomy? Colectomy is the resection of the large intestine. It consists of the surgical removal of any extent of the colon, usually known as segmental resection. In extreme cases, where the entire large intestine is removed, it is called total colectomy. And if the rectum is removed, it is also known as proctocolectomy. It's very important to understand the blood supply of the colon in order to appreciate the various types of segmental resections of the colon that are undertaken. There are two main blood supply sources of blood supply. One is from the superior mesenteric artery, or the SMA, the inferior mesenteric artery, which continues as the superior rectal arteries. The superior mesenteric artery, the first branch it gives off in the right side is the ileocolic artery. Then the right colic artery, which has got an ascending and a descending branch. The third one is the middle colic artery, which gives you a right and left branch, which ends at the splenic flexure. The inferior mesenteric artery gives you the left colic artery, which supplies through its ascending branch from the splenic flexure down through its descending branch to the sigmoid colon. It also gives branches to the sigmoid colon, a few branches to the sigmoid colon. And the main artery continues as a superior rectal artery to supply the upper and middle rectum. In order to understand segmental resection of the colon, it is very important to identify, ligate, and divide the artery that supplies that particular segment that we are going to resect. In the case of the colon, on the right side, you have the artery supplied by the superior mesenteric artery, which arises from the aorta. Its branches which supply the colon are ileocolic artery, which supplies the terminal ileum and the cecum. Then you have the right colic artery, which gives out its ascending and descending branch, and through these branches supply major portion of the ascending colon and also part of the transverse colon. Then the middle colic artery, which divides into your right branch and a left branch. And the left branch supplying the transverse colon as far as the splenic flexure. On the left side, the descending colon and sigmoid colon are supplied by the left colic arteries, the sigmoidal arteries, and the superior rectal arteries, which all arise from the inferior mesenteric artery. The main branch is the left colic artery, which supplies the whole of the descending colon. The sigmoidal arteries supply the sigmoid colon, and the superior rectal artery supply the major part of the rectum. The venous drainage of the colon closely follow the arterial supply. On the right side, the ileocolic veins, the right colic and the middle colic vein will empty into the superior mesenteric vein, which ascends and continues to become the portal vein and goes into the liver. On the left side, the superior rectal vein, the sigmoid vein and the left colic veins will join to form the inferior mesenteric vein, which ascends to join the splenic vein coming from the spleen, which then ultimately joins the superior mesenteric vein to become the portal vein. The next important aspects of the colon is to consider the lymphatic drainage of the colon. Okay, there are 3 tiers of lymph nodes that drain the colon, both on the right as well as on the left. The most peripheral of these is very closely attached, related to the colon itself, and these are known as the epiploic nodes, which are found on the surface of the colon. The next tier is known as the paracolic nodes, which are found between the arterial arcades in the mesentery of the colon, both on the right as well as the left. Okay. Then you have the intermediate colic nodes, which follow the main arteries supplying that segment of the colon. Okay. Intermediate colic lymph nodes. And then the fourth one is the preterminal or the proximal nodes associated or related to the roots of the main arteries, the inferior mesenteric artery and the superior mesenteric artery. These are known as the proximal nodes or preterminal nodes, which will then drain into the para-aortic nodes. Okay, here this is another diagram to show you on the right side the ileocolic nodes, right, and middle colic nodes. Then you have got these left colic nodes here along the left colic artery, sigmoid nodes, and the superior mesenteric nodes, superior rectal nodes. Okay, then the root ones, the proximal nodes, will be the inferior mesenteric nodes and the superior mesenteric nodes. The knowledge of the arterial supply, venous drainage, and lymphatic drainage of the colon are of vital importance when it comes to segmental colectomy or resection for cancer. For complete resection of a tumor-bearing segment of the colon, you should follow closely the arterial supply of the segment, the venous drainage of that segment, and the lymphatic drainage and the lymph node tiers of the related segment. Indications for colectomy. These are the 4 common indications for resection of the colon: colorectal cancers, colonic diverticular disease and its complications like diverticulitis and abscess formation, trauma and injuries to the large intestine, perforation and tears of the large intestine, needs excision or resection of the colon, and bleeding from colonic lesions such as diverticulosis and angiodysplasia. Inflammatory bowel disease is another common condition that needs colectomy. This is especially common in the Western countries. Colitis is another cause. Various infective colitis, radiation colitis, and other forms of colitis which can result in toxic makeup colon, and for which resection of the colon may be indicated because of the massive dilatation and the risk of perforation. Bowel infarction or mesenteric ischemia is another important cause for the need to do a colonic resection. Polyposis coli and pre-malignant polyps are important causes where resection is done as a prophylaxis to prevent the development of colon cancer. Complications of colectomy. Most important initial complication is bleeding from the operative site or the procedure, the process of operating. Secondly, anastomotic leakage and breakdown, which is a serious complication that occurs after the third postoperative day, which can lead to intra-abdominal sepsis and abscess formations. And this can in turn lead to severe septicemia and shock, especially gram-negative septicemia, which has got a very high mortality rate. Then you have the complication related to the stoma, retracted, blocked, or gangrenous stoma. And among the late complications is stricture at the anastomotic site, which can lead to acute intestinal obstruction. Next, we come to preoperative preparations for colon resection or colectomy. Okay, first you need to prepare the bowel. Bowel preparation is very important, and it's the most important preoperative preparation that must be done for the patient going for colonic resection. This can be done by the administration, oral administration of oral fluid or Fortran solutions, which cause massive cleansing of the intestines. Antibiotics, especially cephalosporins plus metronidazole, has to be given either as a prophylaxis or treatment. Patient must be adequately hydrated. If necessary, IV fluids must be given. And preoperatively, patient must be given soft diet and more fluid intake. And DVT prophylaxis is important, especially if indicated as in high-risk patients like obese patients or previous history of DVT or previous prolonged bed rest. This diagram shows the various types of colectomy or hemicolectomy that is done and the blood vessels that must be ligated in each of these hemicolectomies. First, the right hemicolectomy. Okay, right hemicolectomy, which is at the terminal ileum. Is divided at the terminal ileum about 10 to 15 centimeters from the ileocecal junction. Then from the cecum right until the right 1/3 of the transverse colon. Okay, as shown here. So this ascending colon, cecum, and terminal ileum removal, and this is known as right hemicolectomy. And the vessels that are ligated in this right hemicolectomy will be the ileocolic artery here, the right colic artery, and the middle colic artery, the right branch. Next, we come to the extended right hemicolectomy, where the resection is extended to the splenic flexure of the transverse colon. So, cecum, ascending colon, and the whole of the transverse colon are removed. And to do this, apart from these arteries which I already mentioned, the ileocolic, the right colic, and the middle colic, both the left and right branches are ligated. Next, we come to the descending colon on the left side. This is the descending colon. Left hemicolectomy from the splenic flexure right to the sigmoid colon, and that is known as the left hemicolectomy. Okay, and the artery that is ligated in this is the left colic artery. Okay, left colic artery, which supplies the whole of the descending colon, and this left colic artery comes from the inferior mesenteric artery. The next is your sigmoid colon. This is your sigmoid colon, and the resection is known as sigmoid colectomy. And this sigmoid colon is supplied by branches of the inferior mesenteric artery, the sigmoid branches, which must be ligated in order to remove this segment of the sigmoid colon. And the last one is your rectosigmoid colectomy, where part of the rectum has also been removed together with the sigmoid colon. And that is, in this section, we also take the superior rectal artery has to be ligated. Apart from your sigmoid arteries, which have to be ligated, the superior rectoid vessels must also be ligated. Now we come to right hemicolectomy. Right hemicolectomy involves removing the right side of the colon and attaching the small intestine to the remaining portion of the colon. And this is known as the ileocolic anastomosis. In a right hemicolectomy, which involves the removal of the cecum, ascending colon, and transverse colon, these are the arteries that must also be ligated. Okay, the ileocolic artery, the right colic artery, and the middle colic artery. So these arteries must all be ligated in a right hemicolectomy. Okay, and right hemicolectomy is indicated for lesions in the cecum, ascending colon, and the hepatic flexure. So these lesions, especially tumors in any of these locations, you must do a right hemicolectomy as shown in this diagram. Okay, which basically involves the removal of 4 to 6 centimeters proximal to the ileocecal valve to the portion of the transverse colon supplied by the right branch of the middle colic artery. So, and the right branch of your middle colic artery. Again, another diagram of a right hemicolectomy. The area is shaded in yellow here, where the cecum, terminal ileum, ascending colon, and right 1/3 of the transverse colon. They are transected and removed. And the vessels to be ligated will be the ileocolic vessels, the right colic vessels, and the right branches of the middle colic vessels. Right branch is the middle colic, the right branch. So these vessels are all ligated and divided. And then the ileocolic anastomosis is done. Okay, the ileum that is transected, the proximal end, is then anastomosed to the distal end of the transected transverse colon. Then that is known as the ileocolic anastomosis. Extended right hemicolectomy refers to extension of the distal resection margin of the transverse colon to include the distal transverse colon right up to the splenic flexure. Okay, this is a diagram showing you it in right hemicolectomy. You transect here. So in extended, you extend the margin of resection to the splenic flexure. That means the whole of the transverse colon and ascending colon with cecum are transected and removed. And this involves division of the left branch of the middle colic artery. It supplies the distal transverse colon. Okay, This is a procedure of choice for most transverse colon lesions, lesions in the transverse colon, which are rare. So any lesions, especially tumor in this area, you have to do an extended right hemicolectomy. Okay, so in short, it involves the division of the right and middle colic arteries at their origin. Okay, with the removal of the right and transverse colon supplied by these vessels. The anastomosis is fashioned between the terminal ileum and the proximal left colon here. Okay, again, ileocolic anastomosis. Left hemicolectomy. Now, the left hemicolectomy, or left colectomy as it was to be called, is the surgical removal of the left side of the large bowel. Okay, from the splenic flexure right till the sigmoid colon. Okay, and this left colon or left descending colon and the sigmoid colon, they're all supplied by the inferior mesenteric artery. Okay, and the vessels that need to be ligated will be your left colic. Okay, this is your left colic artery. This is your left colic artery here. Okay, which is a branch of the inferior mesenteric. Then you have your sigmoidal arteries. Okay, sigmoidal arteries, maybe more than one, and then it ends as your superior rectal artery here. It supplies the rectum, especially the proximal and middle rectum. Okay, this is another diagram to show you left hemicolectomy. Okay, the distal transverse colon with the splenic flexure and right until the sigmoid colon, and this is known as the left hemicolectomy. And this is usually done for tumors confined to the splenic flexure and the descending colon. Okay, and the left branches of the middle colic are ligated. The left branch of the middle colic here plus the left colic artery itself at its root must be divided, and colocolic anastomosis is created. This proximal part here is then anastomosed to the distal part of the descending colon or sigmoid colon, and that is known as colocolic anastomosis. Okay, this slide summarizes what is extended left hemicolectomy, in which the inferior mesenteric artery is ligated at its root. That means all the supply to the left side of the abdomen or the left colon is ligated. The distal transverse splenic flexure, descending sigmoid and upper rectum are removed. Regional mesenteric pericolic lymph nodes are also removed. So this is told as an extended left hemicolectomy. Sigmoid colectomy. Okay, sigmoid colectomy is the surgical removal of the sigmoid colon with colorectal anastomosis. That means the colon is anastomosed to the rectal stump. Okay, this is a diagrammatic representation of a sigmoid colectomy. Okay, the green shaded area here, removal of the sigmoid colon after the ligation of the sigmoid arteries, which come from your inferior mesenteric artery, and then the proximal end of the resected descending colon is then brought down to anastomose with the top of the rectum. Okay, and that is known as the colorectal anastomosis or rectocolic anastomosis. Next, the anterior resection, or now commonly called the low anterior resection. A low anterior resection, formerly known as the anterior resection of the rectum and colon, and the anterior excision of the rectum, or simply the anterior resection. Formerly it was known as the anterior resection, now it's known as low anterior resection. The common surgery for rectal cancer and occasionally is performed to remove disease or ruptured portion of the intestine in cases of diverticulitis. Next, abdominal perineal resection or AP resection. Okay, what is AP resection? The AP resection is a surgery in which the anus, the rectum, and the sigmoid colon are removed totally. This procedure is often most used to treat cancers located very low in the rectum or in the anus. Okay, less than 5 centimeters from the anal verge and distal to it will end up in most cases for an abdominal perineal resection or AP resection. And this operation is a permanent colostomy is created by the descending colon in the left ilia fossa. This is the diagram to show you AP resection, abdominal perineal resection, the anus, the rectum, and the sigmoid colon. This whole structure, these whole three parts here are totally removed through an approach, through the abdominal approach and through the perineal approach, and two approaches. So the anus and rectum are removed and the perineal wound is closed up. Here, this proximal stump of the descending colon is then used to create a left ilia fossa EndColostomy, which is a permanent colostomy. Okay, here before, this is before the operation. After removing the anus, rectum, and sigmoid colon, the proximal colon is used to create a EndColostomy, which is a permanent colostomy in the left ilia fossa. Next, we come to Hartmans procedure. Okay, a proctosigmoidectomy, that means a rectum and sigmoid has been removed. Hartmans operation or Hartmans procedure is the surgical resection of the rectosigmoid colon. With the closure of the anorectal stump and formation of an EndColostomy. This operation is usually done to treat left-sided colon cancer or inflammation, diverticulitis. Okay, this is the diagrammatic representation of a Hartmans procedure. Okay, part of the rectum and the sigmoid are removed. Okay, rectosigmoidectomy has been removed. Done. The distal stump is closed up and left behind, and the proximal stump is brought out as a EndColostomy. Okay, this is a better view. So the whole sigmoid and rectum, upper rectum is removed. Rectosigmoidectomy, and this is removed. This part A here is removed. Part B is the stump that is left behind, the rectal stump. You close the cut edges have been closed by sutures or stapling and left behind. Then the proximal end of the descending colon, okay, is brought out in the right left fossa as a EndColostomy. Okay, this is allowed to function given time to heal. This whole healing process takes about minimum 6 to 8 weeks, after which this colostomy can be taken down and the stump pre-anastomosed with the rectal stump that is inside. So thereby closing the colostomy and re-establishing colorectal anastomosis. This is a summary diagram to show the summary of all the various types of colectomies or hemicolectomies that are popularly done these days. Okay, you have a right hemicolectomy here, where this right colon is removed, and then the terminal ileum is anastomosed with the transverse colon. So this is right hemicolectomy. This is left hemicolectomy, where the descending colon is removed, and then the splenic flexure is brought down to anastomose with the sigmoid colon. Okay, this is your left hemicolectomy. This is your sigmoid colectomy, where the sigmoid colon is removed, and then the descending colon is anastomosed to the rectum. Okay, so it's your colorectal anastomosis. Then you have the low anterior resection, where the sigmoid colon and the whole of the rectum, as far down as 10 to 5 centimeters from the anal verge, is removed. And then the descending colon is brought down and anastomosed to the rectum, usually using a stapling device. End-to-end anastomosis. Then this is an abdominal perineal resection. Okay, AP resection, where the rectum, anus, rectum, and sigmoid are removed. The anus is closed, and the descending colon is brought out as a stoma, permanent colostomy in the left ilia fossa. Okay, this last diagram here shows you segmental resection of the large intestine. This one, segmental resection of the transverse colon. This can be done any part of the large intestine, and the unresected ends can then be joined in a colocolic anastomosis. Again, I've emphasized the importance of understanding the arterial supply of the colon from rectum right until the cecum. Thereby, you have to ligate the respective arteries or their branches corresponding to the area they supply in the colon. The veins, the left side, from the splenic flexure round to the rectum, the veins drain into the inferior mesenteric vein, which then continues to join the portal system. On the right side, the veins unite to form your superior mesenteric vein, which again joins to form the portal vein. I hope this short talk on colectomy will enhance your understanding of the topic better. Thank you, and see you again in another session.